So as an anesthesiologist, it is our responsibility to ensure that patients receive the highest standard of care, minimizing the risk of complication and maximizing the benefits of regional anesthesia. So as in this presentation, we will delve deep into the key aspects of safety in regional anesthesia, exploring the common complications that can arise and discussing the strategies to preventing, recognizing, and managing them. So by end of this webinar, I'm sure that we will have a better understanding of complication and strategies to prevent the complications. So today I invite our moderator of today's session, Dr. Harshal Wagh. He is a consultant at Kokilaben Dhirubhai Ambani Hospital. He has special interest in regional anesthesia, obstetric anesthesia, onco anesthesia, and his specialty as a robotic anesthesia as well. He is a AORA fellowship mentor for regional anesthesia, has various national and international publication to his credit, and he has been rated as a top doctor in Mumbai as per India Today and Outlook magazine. So all yours, Dr. Harshal.
Thank you so much, Dr. Yogita. And namaste and good evening to all. I first would like to thank ISA Mumbai Metro Branch and the Society of Anesthesia Maharashtra State for organizing this webinar and allowing us to present. It is indeed an honor from the Department of Anesthesia, Kokilaben Dhirubhai Ambani Hospital, to do this webinar. And I have two budding regional anesthetists who are going to be speakers. I have a couple of slides with me. I think the first slide is exactly what Dr. Yogita has sent on the invite of joining this webinar is that, and she has already said it as well, but I'll quickly go through it, is that we all are aware that now with the advent of regional anesthesia, with the advent of ultrasound, the regional anesthesia has revolutionized. Even before ultrasound, people were using it as an effective and sometimes even a safer alternative to general anesthesia. Even as a sole modality or part of multimodal, it has enough evidence to show that it reduces the need of opioids and NSAIDs whenever, I mean, we don't need to give it. However, it's a procedure and any procedure comes with sort of risk and complications. And as everyone is aware that it can be minor complications, but can be even life-threatening ones. And obviously, it is our responsibility as regional anesthetists to ensure that in addition to giving patients highest standard of care, we should also not be first is do no harm. So I think that is something that we should always be in mind. We can continue, Milind, the next slide. So I had this thought in mind that before we point fingers to others in terms of getting evidence on what has been in terms of problems in safety in regional anesthesia and what the case reports have been, it is always best to start introspection in terms of what at least I have gone through through my journey of this regional anesthesia. And if I look back, I think if not me doing it myself, but I've probably been part of all complications that I could think of when I read the evidence and the read few of the theory in terms of safety in regional anesthesia. So wrong side block is something that was very unfortunate, happened with my colleague, but I definitely know that I was part of it. And it was something that is very simple. Patient was, supine when we was thinking of giving the block for a popliteal nerve block. So the patient was on one side. When the colleague went to wash up and came back, because the patient was in prone, the side was opposite, and so the block was done on the wrong side. Last is something that I think many of us must have, when patient starts complaining of perioral numbness. We've had patients who've been have long lasting effects of nerve blocks, maybe some lingering nerve damage as well, which is causing some sort of paresthesia. I remember during my anesthesia days, there was an incidence of paraplegia following a spinal. We unfortunately didn't know the cause at that point of time. PDPH, I've had my own, incidence of PDPH. Dural puncture while citing an epidural is something that even I have gone through. Sometimes the catheter has migrated the epidural into intrathecal and we have to remove it or use it as an intrathecal catheter. I've had my share of failed block spinals and epidurals. I have my colleague put in phenylephrine in an epidural because the 100 ml, which the phenylephrine was kept on the shelf, along with the saline which was used for flushing the epidural, was side by side, and in error and in haste, the phenylephrine was injected in an epidural. When I was in the UK, a colleague of mine, attached the epidural to a central line because both of them were very close to each other. So again, we've gone through everything, and we've published a couple. This is published in the Journal of Regional Anesthesia, where we had two episodes. One was while putting a femoral nerve catheter following, I think it was a knee replacement. While adjusting, the catheter broke. Fortunately, we could see it below the femoral artery, which is depicted on the left side of your screen. And on because it was superficial, we could see it. We got the vascular surgeon involved, and the vascular surgeon found that fragment sitting just below the femoral artery, and obviously we had to explain to the patient and the surgeon, and it was an issue, and he agreed for the publications, which again it's not something that is easily done. We had one more issue. I think Senthil, the next slide, please. Uh, Again, this comes to epidurals and anticoagulation. So we had a bilateral TKR done under combined spinal epidural. In the evening, he had a coronary angioplasty done for ECG changes and received the full dose in heparin during the procedure, full dose of clopidogrel and ticagrelor. And by in the evening, when we came in the morning, I had no idea that the patient was fully anticoagulated. The person who did the angiography did not know that the patient had an epidural. So we got to learn a few things. Now, again, removing that epidural catheter was a big headache because he was on full anticoagulation. So we went through the evidence, we had multidisciplinary meetings. The cardiologist was saying we should not stop the ticagrelor because of risk of stent thrombosis. So finally, what we got to after doing lots of meetings and looking at the evidence is that the ticagrelor, unfortunately, we had to keep on. We stopped the clopidogrel, waited for the clopidogrel for 5 days of its action, and then we removed the catheter, kept observing him from neurological point of view for as long as almost a week after, just to make sure that we are not missing anything. So the important takeaway from this was obviously multidisciplinary. In spite of having all these protocols in place, we still had this. So there are a few things that we discussed, and I think it is important that these things do not happen again. And if they do, you have a plan to look after those patients. Now, I'm going to introduce our first speaker. It is my pleasure actually because both Dr. Milind Shah and Dr. Senthil Kumar have been our Academy of Regional Anesthesia Fellows. This is our first batch in the hospital, and we are proud to have both of them as consultants after their fellowship was done. And they are all budding regional anesthetists and do a lot of work in regional anesthesia. They've also been part of many workshops as far as regional anesthesia is concerned. Senthil has been part of the AORA national conferences couple of times. He's had workshops done in recently the MASCON conference, which was done. Dr. Milin is also someone who does a lot of regional anesthesia. Not only was he a part of our first batch, as I said, but he has also multiple publications. I think Dr. Milin was one of the rare fellows who has had, I think about 8 to 10 publications during his tenure as a regional anesthesia fellow. So I think I'll hand over the session on the talk to Dr. Milin, who is going to be talking about the first part of considerations about safety in regional anesthesia, and then we'll have Senthil talking about the other bit. I believe that Dr. Yogita will take the questions at the end of the session, so that once the entire talk is done, then we'll take questions, because I'm sure you'll have some, and some of your questions might also be answered during their presentations. So, Milind, if you're ready, you can start.
Yes. Yeah.
You can share
Good
your
evening,
presentation.
everyone. Good evening, everyone. My name is Dr. Milind Shah. First of all, I'd like to thank ISA National and ISA Mumbai for providing me with this opportunity to speak today. And also, I would like to thank my guide and my mentor, Dr. Harshil Wagh. I am a practicing consultant anesthesiologist at Cook Lab in Dhirubhai Ambani Hospital. I have done my critical care fellowship and my fellowship in regional anesthesia, which is AORA certified, and I have more than 10 publications in national and international journals. So,
Milind, we can't see your slides.
can't see.
Stop this first, and then you can probably stop my slides. Yeah, better. Carry on.
Is it visible now?
Yes, visible now and just full screen. Yes, thank you.
Yeah.
Carry on.
Okay. Going ahead with today's topic of safety in regional anesthesia, I would be covering the following topics, namely consent, wrong side blocks, aseptic precautions, anticoagulations and regional anesthesia, drug errors, monitoring in peripheral nerve blocks, and local anesthetic systemic toxicity. To err is human, we all know this, but it is better to be safe than sorry. And safety is very important in any aspect because it could cost our patients heavily on the pockets and also could cost them their dear life. So going ahead with the first topic of consent. Consent is when two or more person they agree upon the same thing in the same sense. There are different types of consent. Informed consent, in which there are four aspects that needs to be considered. Voluntariness, that there is no coercion or pressure on the patient to take any decision. There should be a proper disclosure of the risk. The patient should be aware about the risk. The patient should understand what treatment is going to get and what are the risks and benefits he can expect out of it. And the patient should be in the capacity to make his own choices and should be able to retain that memory for long. The other one is an express consent, which can be oral or written. And the third one is the implied consent, which usually follows in the OPD patients. Consent needs to be taken well in advance, except in cases of emergency. We should avoid taking consent in the pre-hold area just before the induction of anesthesia because the patients are usually under stress. They can be pre-medicated, which can hamper their decision-making abilities. Consent are valid for an indefinite period, provided that there is no change in patient's condition or proposed intervention. But yes, it should be confirmed at the time of the surgery. Who can give a consent? Ideally, the patient himself should give the consent if he or she is above 18 years of age. For minors, we can get consent from their parents or their guardians. In case of an emergency, if the patient is in a condition to give the consent, then it's well and good. Otherwise, patient's attendant can give the consent, or if the patient is alone, then it's not required to go. Then it's not required to go ahead with the surgery. We can go ahead with the surgery without the consent. In case of an incompetent patient, the companies of the patient can give the consent. What should the consent form include? The consent form should ideally include the name of the patient, the age, gender, hospital ID of the patient, date of the surgery, name, signature, date, time of the anesthesiologist, the surgical procedure that the patient is supposed to undergo, the type of regional anesthesia that the patient is supposed to undergo, the risk that the proposed type of anesthesia imposes on the patient. What can the patient expect out of the anesthesia that is going to get? What are the comorbidities that the patient has? Two important things that also needs to be documented is that the patient has been informed about the procedure and the risk, and that the patient has been given ample time and opportunity to discuss and ask questions. Consent is for doctors to seek and for patients to give. It is not something, which can be taken by coercion or by pressure. It's a process. It is not an event. It involves a dialogue between the doctor and the patient. While all the risk must be explained, the doctor must not bombard the patients with information that is likely to cause confusions. Patients should be informed about all treatment options, including the option of no treatment. How much to tell the patient? It depends on the individual patients and what they want to know. We should tell common complications like that of regurgitation and aspiration that follows in general anesthesia, rather than telling about a remote complication like long-term nerve damage following an epidural needle. Avoid using descriptive terms like high risk, low risk, and it is better to communicate in numbers rather than communicating in percentage like 1 in 10 rather than using percentages like 10%, 20% risk. It is important to have a consent for blood transfusion because the patient can be a case of Jehovah's Witness, and it is important to have a fresh consent for every repeat procedure. if we don't follow this guidelines and ethics in our practice and taking consent, then we as anesthetists who usually stand behind the patient might someday be standing in front of the courtroom for an indisciplinary action, and we have to face that. So just to summarize, information should be provided to the patients as early as possible, and it should ideally be in written or online format, which can be referred to for future. New information should only be provided to patients immediately before anesthesia in exceptional circumstances. Patients should be invited to ask questions, and this should be addressed and documented. Discussion of options should be fully documented, including that of risk, benefits, alternative, including no treatment. The only exception to providing information is when the patient has consistently expressed a desire to not to know the risk. If informing the risk to the patient would pose a serious threat beyond that of distress, and in emergency situations. It is a good practice to obtain written consent for independent procedures like that of central line insertion or any invasive pain procedures. Consent is an ongoing process and it may require repeated discussion. Obtaining consent is the responsibility of the individual who is performing the procedure. Patients can qualify to consent by refusing the aspect of treatment, like that of blood transfusion and Jehovah's Witness. A discussion of the risk should be documented. Regional anesthesia carries very specific risk and benefits, and where there are usually viable alternatives available with different risk profile. A highly technical skill set is required for successful and reliable regional anesthesia blockade, which means that the procedure is very operator dependent and the patient needs to be aware about practitioner specific information. The next topic is wrong side block. The incidence of a wrong side block is around 0.5 to 5 in per 10,000 cases. How can we prevent a wrong side block? We should implement a WHO surgical safety checklist wherein we do in a sign-in procedure just before the induction of anesthesia. We should follow stop before you block and we should confirm with the patient. There should be a surgical mark at the site of the surgery which will help us to reconfirm the same thing again. It is important to confirm the site of the surgery if there are more than one procedure of regional anesthesia to be performed on the same patient, or when the patient is getting repositioned, as Dr. Harshal mentioned about prone and supine position, the right can become the left can become the right. It is always better to ask the patient to cross-confirm with the consent form. Distractions in the operation theatre or the procedure room should be as minimal, and every personnel present in the operation theatre should have the capacity and they should feel free if they feel that a wrong side block is about to occur. Next is aseptic precautions. Infectious complications related to regional anesthesia are rare because they are likely to be underreported. The incidences of CNS infection following a central neuraxial block is around 2 in 1 lakh, and that for a spinal anesthesia is around 1 in 1 lakh. But the cases of infectious complications in a peripheral nerve block catheter is around 1.8%. How can the infection occur? Through microorganisms from patients or anesthesia practitioners' flora, which get inoculated directly with the catheter or the needle that is inserted at the nerve block site, with the absence of prophylactic antibiotic, because of prolonged duration of in situ catheters, because of catheters at femoral and axillary site, and infrequent dressing change that occur at the catheter site. Common organisms causing infection are streptococcal, staphylococcus, and pseudomonas. How do we diagnose it? From local tenderness, radiological evidences like that of a mass in the epidural space or at the peripheral nerve block site, which is consistent with an abscess within 30 days of intervention. Now talking about chlorhexidine. Chlorhexidine is a very potent and a broad spectrum antiseptic. It has a fast onset and a longer duration of action as compared to iodine. And it works effectively well even in presence of blood. So there are reports that the chlorhexidine is subsequently and slowly replacing iodine. There are two concentrations of chlorhexidine commonly available, 0.5 and 2% of chlorhexidine, of which 0.5% chlorhexidine is routinely preferred because it is less likely to cause neurotoxicity and arachnoiditis as compared to the 2% chlorhexidine. Because it is said that even 2 drops of or 0.1 ml of antiseptic at the site of nerve block or within the nerve can cause adhesive arachnoiditis. How can we prevent all these complications? We should minimize the risk of contamination of equipments used for regional anesthesia with antiseptic solutions and avoid their contacts coming with that of the neural tissue. We should not pour the antiseptics in the same tray in which the regional anesthesia equipments are kept, and the regional anesthesia equipments should be covered until the part for the blockade is prepared. It is recommended to apply the chlorhexidine for at least 30 seconds to the skin, and importantly to allow it to dry completely. A single dose antibiotic prophylactic is associated with a reduced risk of catheter-related infection for peripheral and epidural catheters, and it should therefore be considered immediately before or shortly after the procedure. Tunneling of long-term catheters is recommended in order to reduce the risk of colonization of catheter tips. We should remove the jewelry that we use. We should use an alcoholic hand rub. We should wear a mask, sterile glove, gown during insertion of indwelling epidural or peripheral nerve catheters. There is no consistent data to recommend the use of surgical gown for a single shot procedure. The transducer should be covered with a sterile plastic dressing or a cloth. There should be a transparent dressing used for surveillance of catheter site infection. The anesthesia personnel should observe their patients closely for signs and symptoms of infection so that infections can be diagnosed and treated immediately. A sterile jelly should be used. Cleaning of ultrasound probes after procedure is important, more so for the bloodborne infections, because viruses like HIV, HBsAg, they are known to survive on inanimate surfaces for more than 1 week, which can be transferred from patients to patients. So cleaning the transducer, the cable with proper antiseptics is very important. The patient should be covered with a sterile draping. Bacterial filters should be used for epidural infusions. We should look that there is limited disconnection and reconnection of neuraxial delivery system to minimize the risk of infectious complications. Consider removing unwitnessed or accidentally disconnected catheters, and catheters should not remain in situ for longer than clinically necessary. Here is a picture in which the epidural bacterial filter got disconnected from the yellow connector, and the local anesthetic started to ooze and cause bedwetting. It only came to our notice after we went for the evening rounds that the patient had accidentally that there was an accidental disconnection of the epidural filter and the catheter with the epidural catheter. So it is very important to take routine rounds and follow up our patients regularly in whom indwelling catheters or peripheral nerve block catheters are placed, and also to monitor for signs and symptoms of any infection that they are present. If you suspect any infection, then remove the in situ catheter and consider sending the tip for culture. Use appropriate blood test, antibiotics, and if there is an abscess which is suspected or any neurologic dysfunction is suspected, then proper imagining studies should happen, and the subsequent subspecialties should be involved. Anticoagulation in regional anesthesia. It is very common for us to have patients for lower limb orthopedic surgeries, for prostate surgeries, who are on anticoagulants because they are elderly, they have multiple comorbidities. Most common indications for anticoagulations are arterial or venous thromboembolism, atrial fibrillation, patients with mechanical heart valve with past history of myocardial infarction, pulmonary embolism. Now, the thing with anticoagulants are, if they are abruptly stopped, they can cause rebound hypercoagulability, or their undue continuation will pose a threat of bleeding, hematoma, or paraparesis. So the need to stop the anticoagulants before regional anesthesia is to prevent bleeding and hematoma, especially for deep blocks at non-compressible sites, which are usually the lumbar plexus block, the paravertebral block, the infraclavicular block. Here you can see on the right side the picture of an infraclavicular block where there are major arteries and veins, just around the plexus of the nerve. On the left side, there's a picture of paravertebral block where you see aorta, the IVC, just running around the site of our needle prick. ASRA had put guidelines for anticoagulations in central neuraxial blocks, which should also be followed for deep blocks. That's what they recommend. But we can be a little lenient if we are performing a superficial peripheral nerve block. These are the ASRA guidelines that are widely available and easily available everywhere, so I will not go much into its detail. Just a couple of points that the low molecular weight heparin, enoxaparin that we routinely use for our post-op patients is usually started 24 hours after the surgery. If the catheter is placed in situ, it needs to be stopped at least 12 hours before we plan a catheter removal and can be started 4 hours after the catheter has been removed. Also, we should be aware about the novel oral anticoagulants that are now widely and routinely prescribed for cardiac patients, and how long that we need to hold it before any regional anesthesia procedures. There's definitely ecosprin 75 milligrams, which the guidelines now suggest that it's okay to continue ecosprin 75 milligrams even for doing a subarachnoid block. Then, as Harshal sir mentioned, that case of an epidural who went into MI and had to undergo a PTCA, that we need to at least wait for 6 weeks for a bare metal stent if it's placed in situ, or for at least 6 months if there is a drug-eluting stent. The next one is drug error that we commonly encounter in regional anesthesia. There are reports suggesting that the incidence of drug error is around 1 in 133 cases are the anesthesia that we give to our patients. What are the routine causes of drug error? Failure to check the drug before administration. If there is a syringe swap or ampule swap that occurs because of lack of communication, because of lack of standardization of labelings and protocols, the busy workload, multitasking, and tired working culture that we have, because of poor cart organization, ampules that look alike, unclear or unreadable drug labels that we have. Most common cause of drug error is because of drug administration. And drug error usually means inappropriate dosing or wrong sequence of drug administered. Drug which was not intended to be administered got administered, or the drug which the patient was allergic to got administered. Here on the right side, you can see the picture of a look-alike ampules of bupivacaine heavy used for spinal anesthesia, and then of a tranexamic acid. There are n number of intravenous drugs and n number of reports that are available in which the intravenous drugs were accidentally injected into the subarachnoid or space or epidurally. Commonly, to name some, are tranexamic acid, myopyrrolate, magnesium, many of the cardiac intravenous drugs that are used. And also, there are reports in which the drugs which are used for local anesthesia are accidentally injected intravenously or through the central line. So what we need to do to avoid this is to have proper labeling. A visible label should be placed, colored label should be placed around the epidural catheters. The ward nurses should be appropriately instructed and educated about it. Now, what are the BGA recommendations to avoid these drug errors? There should be a color coding of the syringes. When mistakes happen, then the patient should be resuscitated, investigated properly, and it should be reported, more importantly. The critical incidents should be reported. 2% confirmation or double checking of the drug should always happen. Drug should be drawn up and labeled by the anesthetist who will administer them. And drugs should be present in a prefilled syringes rather than in ampoules. Next topic is about monitoring. Why do we require monitoring in regional anesthesia? Is so that we can be warned about the impending harm that can occur to the patients. The three main important tools of monitoring in regional anesthesia are the nerve stimulator, the ultrasound, and the injection pressure monitor. Apart from this, the minimum ASC guided standard monitors of ECG, NIBP, and SpO2 should always be on during the procedure and even after the procedure for at least 30 minutes. Now, talking about the nerve stimulator, a motor response at 0.3 to 0.5 milliamperes of current usually means that there would not be any nerve injury. But if you get a motor response at less than 0.2 and less than 0.3 milliamperes of current, that means the needle is most likely placed intraneurally, and injecting a local anesthetic there would cause the nerve inflammation. So we should stop injecting, withdraw the needle, and redirect the needle. Even in absence of the puncture of the epinurum, a forceful contact of the needle with the nerve can also cause inflammation and potential nerve injury. The other important use of a nerve stimulator is for functional confirmation of a specific nerve with the specific motor response that it elicits. Now, there are cadaveric studies in which they say that intraneural but extravascular injections of local anesthetics are considered to be safe without causing any nerve injury. This is an area of study and needs further exploration. Benefits of ultrasound: it helps us in real-time imaging. It helps in accurate placement of the needle and local anesthetic around the plexus. It helps in visualizing the local anesthetic spread. It allows to perform the peripheral nerve block in whom the motor response cannot be elicited, like that in amputate patients or in patients who have had some kind of paralysis. It improves the safety. It avoids important structures and vessels. It helps in reducing the volume of local anesthetic dose and thus the systemic toxicity. Currently, ultrasound also has been widely used in focus and in identification of complications like pneumothorax, which can occur following an supraclavicular block. The third is the injection pressure monitor. If the opening pressure of the injection pressure during injecting a local anesthetic exceeds 15 psi, that means we are dangerously in close contact with the nerve, and then we should stop injecting. There are two companies, B. Brown and P. Jung, who are supplying the pressure monitors. The first one is the nerve guard, where the nerve guard would not allow the syringe to inject the local anesthetic if the pressure exceeds 15 psi. And the second on the right is the nerve injection pressure monitor, where there are three readings of 15, 15 to 20, and more than 20 psi, which would get popped up as and when the pressure for the local anesthetic injecting would increase. Third tool that we can have for monitoring is epinephrine, where we can use epinephrine with some local anesthetic, as it would help in intravascular absorption confirmation by increasing the heart rate by 10 to 15 beats, or increasing the systolic pressure by around 15 millimeters of mercury. 10 to 15 micrograms of epinephrine is that what we routinely use with other local anesthetic as the test dose. Now, there are multiple reports of triple monitoring and double monitoring that we use for regional anesthesia, peripheral nerve block especially. It's been reported that the ultrasound nerve identification supported by nerve stimulation localizes the target in more than 98% as compared to 90% and 81% when stimulation and ultrasound techniques were used separately. Now what we routinely follow is the triple modality of monitoring in the regional anesthesia. Lastly, talking about local anesthetic systemic toxicity, the incidence of local anesthetic systemic toxicity is around 1 to 2 episodes in every 1,000 peripheral nerve blocks, and still it is underreported and misdiagnosed. Around 19% of cases of systemic toxicity occur in upper and lower limb blocks, and 14% occur in neuraxial blocks, particularly in paravertebral and epidural nerve blocks. Why are they caused? Because of high volume of local anesthetic used in facial plane approaches, because of continuous catheter techniques, because of multiple local anesthetic techniques used in the same patients. What are the different types of local anesthetic toxicity? It can be a local toxicity or an allergic reaction to the preservatives used, which is most commonly PABA, or which can cause myotoxicity, neurotoxicity, or the systemic absorption, which can cause neurologic or cardiac toxicity. What is the mechanism of toxicity? It's because of inadvertent intravascular injection or systemic absorption from the nerve block side. Local anesthetics, they block the voltage-gated sodium channels. Not only block the voltage-gated sodium channels, but they also can inhibit the calcium channels, potassium channels, sodium-potassium ATPase, the mitochondrial metabolism. Bupivacaine, which is lipophilic and it has a greater affinity for sodium channels, it accumulates in the mitochondria and the cardiac tissues at the ratio of 6:1 relative to the plasma. And so it is more associated with cardiac toxicity. What are the risk factors for local anesthetic toxicity? It can be local anesthetic related, the type of local anesthetic, lipophilic drugs. Levobupivacaine and ropivacaine, they are intrinsic vasoconstrictors, which can prolong the duration of action and can slow the systemic absorption. There is a cardiovascular collapse to CNS ratio, wherein the lower the ratio means more the cardiac toxicity. So bupivacaine, which has a ratio of 2, is more cardiotoxic as compared to ropivacaine and lignocaine. Then that comes about the dosing of lignocaine, bupivacaine, ropivacaine, the maximum tolerable doses, which would relate to the peak plasma levels of local anesthetics. Block related, the site of the block, interscalene block, stellate ganglion block, where there is a direct and a high risk of direct intravascular injections are more likely related with LAST. If there is rapid absorption from a highly vascularized area like intercostal, which is more than that of epidural, than that of caudal, than that of epidural, brachial blocks and lower extremity blocks. Single shot versus continuous infusions. The conduct of block should happen with frequent aspirations. A small text dose should be given, hydrodissection should be done, adrenaline should be used, an ultrasound should be used. Patient-related factors, if there are comorbidities with the patient, any renal, hepatic or cardiac comorbidities with the patient in an elderly or pediatric patients, pregnant patients. How can we prevent LAST? Before the procedure, there should be standard monitoring and proper labeling of the drugs. During the procedure, there should be frequent aspirations, slower injection in small aliquots. There should be continuous communication with the patient, use of all modalities of monitoring. And after the procedure, there should be proper labeling, documentation, and follow-up of the patient. What are the symptoms of LAST? CNS symptoms usually precede the cardiac symptoms. Blockade of sodium channels of the inhibitory cortical neurons in the CNS occur first, thereby causing the excitatory symptoms. 40% can present with sudden rapid onset of seizures, which can progress to cardiac arrest. With high dose or intravenous injections directly, the early CNS symptoms may be absent and the first manifestation can be with the cardiac symptoms. In around 11% of cases, that can happen. So, what are the prodromal symptoms of LAST? We can have perioral paresthesia, numbness, metallic taste, tinnitus, CNS symptoms, which can be excitatory, followed by depression, loss of consciousness, drowsiness, and coma. Cardiovascular symptoms related to conduction abnormality, relate to decreased contractility and vascular resistance, ECG changes, cardiogenic shock, refractory hypotension, and ultimately cardiac and respiratory arrest. How can we diagnose? Last can occur immediately after the injection of local anesthetics in a nerve block, or it can occur up to an hour after the injection, so they should be followed up accordingly. Monitoring should occur for at least 30 to 45 minutes after injecting a large volume or toxic dose of local anesthetic. You should monitor the patients with any signs of last for 2 to 4 hours, because the cardiovascular depressions can persist or it can recur even after the treatment. How will you manage it? There should be simulations available. There should be copies of guidelines available in the operating room. Essential drugs and equipment should be available. It is important first to identify that a systemic toxicity of local anesthetic has occurred. Stop injecting the local anesthetic, call for help, follow the protocol of airway, breathing and control, give 100% oxygen. If you find a cardiovascular collapse, start with a cardiovascular resuscitation. In any seizures, you can use benzodiazepines. Propofol is usually avoided because it will aggregate your hypotension and cardiac suppression. Follow ALS protocols. Vasopressin is avoided because the intense vasoconstriction that it causes will further depress the cardiac output. And the magic drug intralipid should always be available within the premises. It works on the theory of lipid sink, in which it increases the local anesthetic clearance by extraction of local anesthetic from cardiac tissues, and lipid counteracts local anesthetic inhibition of myocardial fatty acid oxidation, which releases the energy and it reverses the cardiac depression. This is the protocol for management. You support the ventilation, address the central nervous system symptoms of seizures, initiate cardiovascular life support, call for help, and the lipid emergent therapy you can start with a bolus of 1.5 ml per kg, and you start with an infusion of 0.25 ml per kg per minute. Then you assess if the patient has become stable, continue the infusion for 10 minutes and then monitor for the next 12 hours. If there is persistent cardiovascular instability, you can repeat the bolus dose of 1.5 ml per kg. And if there is hypotension, you can double the infusion. Still from my side, thank you all. I would like to hand over and invite Dr. Senthil for his part of presentation. Thank you.
Thank you, Milind. That was quite nicely put. We'll take questions at the end. We already got 2 questions, but as we'll let Senthil finish his talk. I've already spoken about Senthil. So Senthil again was our part of Milind's batch. So both of them were our first batch of regional anesthetists. He has been part of many workshops as well. Senthil, I'll hand it over to you. Carry on.
Little bit, this is about me. So I have 3 public.
I'm supposed to do that. So your slide wasn't up. So let me do it.
Sir. Okay.
Yeah, okay. So since he's written, so he was a topper in the MD in all over Maharashtra in the MUHS. He has received the Best Assistant Professor Award in JJ, and he's done fellowship with us. He's on the social ambassador team of the EORA as well, and the Executive Council of ISA Mumbai Metro Branch. He has been invited faculty for many workshops. He has sort of 3 publications on his this thing, and a couple of more coming up as well. So, Senthil, over to you.
Yes, sir. Thank you very much for the kind introduction, sir. You are an inspiration. Though my publication is 3 right now, I will have the catch-up growth in the future. I hope I am audible.
Yes, please.
Yes.
Yeah.
Good presentation, Milind, and I would like to thank ISA Mumbai Metro Branch of course, Dr. Amla Kudalkar ma'am and Yogita Patil ma'am for giving us this opportunity to present in a good and a very relevant topic of today, and SAMS also, Society of Anesthesia Maharashtra chapter, for this opportunity. What I'm going to talk is going to be more of procedure related, clinical, and as of now, as of date, we have moved from the landmark guided or paresthesia guided blocks and PNS guided blocks to the ultrasound guided blocks. So the topic is going to be around the ultrasound guided blocks and its complications and how to have a safe practice around it. I'm going to have a nerve injury, how to prevent nerve injury, vascular injury, and whether to give safely the blocks for patients who are going to develop a compartment syndrome and with central neuraxial blockade, PDPH, then Phrenic palsy, pneumothorax, and a little bit on whether to give the blocks when the patient is awake or asleep, what it is as of today. So a little bit of the basics just to brush the anatomy of nerve injury before we understand what it is. And a disclaimer, few of my slides from the nerve injury is going to be a little bit of a repeat talk because I had given this talk in MASCON this year. And so bear with me, whoever has listened before. Now, the nerve injury post regional anesthesia nerve block given by us come under this post-operative neurological symptoms, or we term it as perioperative nerve injuries. And the anatomy, we have axon covered with the myelin sheath, and the covering that covers the axon is your endoneurium, and groups of axons are together in a tough non-tensile sheath called the perineurium, and the entire nerve is covered by your epineurium, and there is a layer distinct from the epineurium which is called as the paraneural sheath. So as of today, there are places like sciatic nerve where the paraneural sheath is distinctly delineated or described, and we deposit the drug in the subparaneural sheath, which is called the sweet spot of the nerve, and that is where we deposit the drug safely. And there are studies and there are people who practice intraneural injection extravascular, which means you deposit the drug outside the perineurium safely. And we have an extrinsic vascular supply and an intrinsic vascular supply. When it is injured, then patients can have hematoma and patient can have pressure, ischemia on the nerves and nerve injury. So what is an intraneural injection? Which is a subperineural injection which causes a swelling and a compartmentalization of the nerve. So the intraneural injection can be an extravascular injection and an intravascular injection. So intravascular injection becomes the injection that is done piercing the perineurium. And this is important to understand in relation to nerve injury. The nerve elements is to connective tissue ratio, because the proximal nerve plexus, say where you target the roots in interscalene block, where the nerve elements are more in comparison to the adipose tissue. As you come down from the root level and to the distal level, say in the axillary brachial plexus block, where you have nerve elements that is little lesser, or adipose tissue which is more in comparison to your nerve elements. So you have a buffer of an adipose tissue where you can deposit your drug and avoid nerve injury. Whereas the nerve injury, and if you can see the incidence of nerve injury, which is more with interscalene nerve block, obviously because of this reason. Now, we all know that the Sedan and Sunderland classification, the original was neuropraxia, axonotmesis, and neurotmesis, and the modified by Sunderland as one, and yes, divided axonotmesis into 2, 3, and 4. And with respect to nerve injury, the nerve injury is mostly a neuropraxia, which is a conduction block. And the permanent nerve injury by producing an axonotomosis grade 4 or neuronotomosis is less. Now, what is 2, 3, and 4 of axonotomosis is the axonal disruption in 2 and one second. Where 3 is axonal disruption with the endoneurium disruption, and 4 will be axonal disruption, endoneural disruption with perineural rupture and fascicle disruption. And neuronotomosis is the complete transection of the nerve. So if you see the type 1 injury where there is complete reversal of function within days to weeks, and if you see among the axonotomosis, the recovery is variable, and type 4 where the prognosis is poor as of, and you will not have the function back as of neuronotomosis. So still with ultrasound guided blocks, nerve injury is possible, and to see that how frequent, yes, it is there. If you see the peripheral nerve injuries after regional anesthesia is around 0.21 to 0.4%, which is very less if you can see absolutely, but because of the underreporting of the nerve injuries that is there. So NICERA suggests 0.3% for femoral blocks and 3% for interscalene blocks, for the very reason that I've told you before, the nerve is to adipose tissue ratio. And the latest estimates of temporary nerve symptoms like neuropraxia, which is reversible, the incidence is 0.20 to 2.2 at 3 months, and 6 months is 0.8 and 0.2 at 1 year. So the incidence decreases at 1 year. Now, the permanent nerve injury, to produce it's difficult. The range is from 0.014 to 0.04, which is meager. Now, this is about the popliteal nerve blocks, which is in the lower limb, 0 to 10%. And unintentional intraneural injection with anatomical guided axillary block was 85%, and popliteal block was 88% with ultrasound. Now, what is the mechanism? So how is the nerve injury produced? So it is 3 of these. One is mechanical, another is ischemic and chemical. Mechanical is due to the needle-induced trauma or the catheter-induced trauma. Ischemic is the hematoma produced by the vascular injury or the vasoconstriction produced by the additives, say the adrenaline we use, or if you injure the intrinsic vascular supply, then the pressure ischemia that is causing on the nerves can cause the nerve injury as well. So when you actually interrupt the perineurium, the axons are exposed to the local anesthesia, and the axon damage will be very severe. So intraneural injection, intrafascicular injection is dangerous more than the extrafascicular injections. And chemical, the local anesthetics that we use by itself is neurotoxic, and the additives that we use and the gel that we use for the ultrasound guided blocks, betadine and chlorhexidine, you all know, and it was talked by Milin also. And these are my 2 references for the nerve injuries. Now the mechanical, if you see the sharp and the blunt needles, of course the sharp needle is going to produce more nerve injury, and blunt is going to be less. But if this blunt needle goes into the intraneural, intrafascicular injection, then the injury produced by the blunt needle is more than the sharp needle. As such, the sharp needle is going to cause you injury when you are in the intraneural position, but blunt will cause more damage than the sharp when it is in the intrafascicular region. Now, of course, long bevel and short bevel. Long bevel is going to cause more injury, so use short bevel and blunt needles in order to have a safe practice of regional anesthesia. Then ischemic, of course, hematoma because of, and the vasa nervorum, which supplies the nerve, and the adrenaline that we use because of the vasoconstriction. Now, among all the local anesthesia medications, the ropivacaine is the ropivacaine is the least with neurotoxicity. Sorry. And the proposed mechanism is a mitochondrial metabolism.
Just make full screen, Senthil.
Sir,
Full screen.
okay. 1 second. Yeah.
Yeah, good to go.
Yeah. Now the patient factors, if you see diabetes people, where we reduce the dose of local anesthesia for giving the safe regional block for those people, because the diabetes smoker, there is a tenfold increase in the incidence of nerve injury in these people. And of course, extreme BMI, there is poor resolution of the ultrasound because of the adipose tissue, there is poor ultrasound, and there is a depth at which we have to give the blocks. So definitely extreme BMIs and thin patients, of course. Then elderly patients is another factor where you will have to be very careful in giving the blocks. Then the other entity is pre-existing neurological disorders, like the double crush phenomenon we usually say, because the double crush phenomenon is nothing but there is a primary nerve lesion in one place, and there is another insult, a low intensity insult at some other place along the neuraxis. Then it is going to cause nerve injury more, like where patients who are having cervical stenosis can develop carpal tunnel syndrome as well. And there are various neurological disorders which is metabolic and hereditary and all those things, where we will have to be careful in giving the blocks. Now, the surgical risk factors, which are very important in nerve injury, because it's not only the nerve block that we are giving is going to produce nerve injury, improper patient positioning, of course, which is from our side, and the compression, stretch, the traction, and the transection that the surgeon can do with the nerve when when he is doing his open reduction and internal fixation, say the orthopedic surgeries. Then the tourniquet that we use compress the pressure ischemia that it causes directly to the nerves as well as to the blood vessels, and the vascular compromise and the hematoma of the surgery, then the cast compression and the irritation. And there is something called as post-surgical inflammatory neuropathy, which we will have to know, because it just a patient who is having post-surgical inflammatory neuropathy can present to you with nerve injury. As such, your nerve block would have not caused about it. It's not the cause for it, but post-surgical inflammatory neuropathy would be the cause, which we have to know as a differential diagnosis in patients coming with nerve injury, sensory neural deficits or paresthesia or pain. So it's an immune response to the stressor of surgery which affects the PNS. It can be multifocal or diffuse within the limb. It could be a one nerve involvement as well. Distribution distinct from the surgery or regional anesthetic, wherever we have given the regional anesthesia, but the neuropathy is elsewhere in the distal this thing, or patient is going to have severe pain which can be atypical, unexplained, and refractory as well with your symptomatic management. The neuropathy or the nerve injury is going to be more proximal than the distal, and the pain is going to be more proximal than distal. Weakness can be there, sensory deficit is present, and the mechanism that they have implicated is microvasculitis, which causes axonal loss. And so, how to diagnose intraneural? How we know that we are giving an intraneural injection? One is the visualization of the needle tip during penetration of the nerve that we see, or inside the nerve in adjacent to the hypoechoic spots that the nerve plexus, and the indentation of the nerve wall followed by the puncture, and expansion of the cross-sectional surface area of the nerve, and there will be a change in the echogenicity from the actual echogenic nerve. Now this is how it is. This is the nerve and this is the needle. You can see the penetration of the needle. This is the increase in the surface area of the nerve post block intraneural injection. Now there is this article, ultrasound of the peripheral nerves, which described intraneural injection with dynamic signs and static signs. Dynamic signs, one is the visualization of the needle inside the nerve, which is most important criteria. The other thing is the dynamic observation of the nerve's cross-section area, which increases, which you can see direct visualization when the nerve distance, when you give the local anesthesia with fascicular separation. By virtue of it, you will have the diameter of the nerve, which is increased. You can see this is the architecture of the nerve, and then this is an intraneural injection. The surface area is increased, the diameter is increased, and there is real-time distension. So I'm sorry I could not show you a video. Obviously, we are not going to intentionally give an intraneural injection. The other thing is that elastic reduction of the intraneural area after injection is stopped. So once you stop the surface area and the cross section area decreases once you stop the injection, and which suggests that the epineurium has an elastic distension property, and which will disappear with recoil or rupture of the epidural cover and when the injectate is stopped. The static signs is just the increase in the cross-sectional area of the nerve and the diameter. And there is a longitudinal spread of the injectate, which can create a fine halo in the proximal and distal direction. So if you move your probe from proximal to distal, you can see a halo around the nerve from the proximal to the distal side. I think this is the sciatic nerve that they have shown. Now, definitely nerve swelling, which is I said, change in the echogenicity due to edema or to an increase the aqueous tissue content. So there is a high correlation between this nerve swelling and cross-sectional area.
अच्छा अच्छा एक तो इसमें वो रखा हुआ है स्टिपलर
Somebody has not muted their.
We'd request the rest of the participants to please mute.
And now the major criteria is, one is the visualization of the needle inside the nerve and increase in cross-sectional area. So these two are very important because it has a sensitivity and specificity close to 100. And the other minor criteria is nerve swelling, elastic reduction of the nerve area, the halos, and the distribution along the branches. So which has a sensitivity and specificity around 75 to 65%. So needle inside the nerve and increase in the cross-sectional area, which is very important. Now, what are the other things other than what we see in the ultrasound? Paresthesia or the pain that the patient tells you, then you immediately stop. But there is nothing, there is no studies or things said that even if your needle is inside the intraneural area, still the patient cannot have the pain. And the patient can have pain even in the epineurial region. When you pierce the epineurium, I think Millennials also mentioned about that. So even when you pierce the epineurium, the patient can have pain, but you are not in the actual intraneural area, intravascular injection. So the paresthesia pain, for all practical purposes, if the patient is complaining, then you stop the injection. And with respect to PNS, when the motor response is less than 0.2, if the motor response is present less than 0.2, is definitely an intravascular intraneural injection. Then you immediately stop and withdraw. Then injection pressure around more than 15 psi, definitely you will have to stop, which suggests intraneural injection. So what next? This is an article by our own Balavenkat sir and the others from Ganga Hospital who had devised a management diagnosis protocol for what next to do if patient is developing a nerve injury post-block. And this is symptom categorization, history, examination, diagnosis, and management, which they have told it as SHED. Now, this is the symptoms categorization, whether minor or major, then surgery related to rule out. You first have to rule out surgery related, then anesthesia related. Then you examine for DVT, the pain, the causes of pain other than the block or the nerve injury, the DVT and the ischemia. Then you do a sensory examination and a motor examination and a local examination if the patient is having external compression by having a tight cast or a slab or a bandage, and in internal compression patient is having an hematoma or swelling. Now, how will you diagnose? Within less than 24 hours, the patient is there, then you do a MRI and high resolution ultrasound to study the morphology of the nerve and the nerve lesion. So 1 to 2 days, you do a nerve conduction study, you detect the nerve lesion, and you see for the current amplitude, which will tell you about the axonal damage, and the nerve conduction velocity, which will tell you the conduction damage to the myelin. And 2 to 4 weeks, you do an electromyography where you can locate the nerve lesion, and a positive EMG less than 2 weeks, which can suggest you a pre-existing neuropathy that the patient is having. Now, how to manage? You treat the cause, you involve multidisciplinary symptomatic relief, you reassure and inform the patient about the follow-up, which is very, very important with patients who come with nerve injury. Multimodal analysis and regular follow-up, multidisciplinary approach. So physiotherapy and everything that we do it. And This is an algorithm by Regional Anesthesia UK. Sorry. Now, any new onset pain and weakness, numbness, any sensory neural deficit, usually which lasts beyond the usual duration of specific block. So whatever block that we give usually lasts for 48 hours if it is a single shot block. Now you review with your history, anesthesia record, surgical history and everything. Then if it is mild and persistent, you reassure the patient and review the patient in 4 weeks. If the persistent symptoms are not there, then no follow-up is required. If it is there, yes, you have to give a neurological referral, consider MRI and imaging, nerve conduction studies and EMG. Then manage accordingly. Otherwise, if the patient is having a complete or progressive neurological deficit or presence of motor deficit, then you call the acute pain service, you involve the surgeon for any hematoma, cut, stretch injury, then decompression, reconstruction, then your nerve conduction studies and EMGs, and then follow up accordingly. Now, how to prevent the nerve injury? So, of course, prevention is the key. So, what are the safety precautions? So use triple modality, which is the safest, which is PNS, USG, and injection pressure monitoring. Always the needle tip should be visualized. It's not important that you see only the shaft of the needle tip visualization, which is more important than the shaft of the needle. Then use of short beveled blunt needles, as I've said before. You plan a good needle trajectory, because if you take a sciatic nerve, then you want to block the tibial nerve. The common peroneal nerve might be in your needle trajectory sometimes, so you don't want the common peroneal nerve to get damaged. So you planning of a good needle trajectory is also important. And patient selection, of course, I said patient factors and surgical factors are such. So patient selection, and be careful in the high risk patients. Then, of course, do a nerve block in an awake patient only, so that the patient can complain of pain or paresthesia if we touch the nerve. Another is use of ropivacaine rather than bupivacaine or lignocaine. Then you use an optimal volume and concentration and the dose of local anesthetic, so that the exposure of the volume and the dose of local anesthesia to the nerves is less. And as I said, subparaneural injection, or the sweet spot of the nerve, which is getting evolved, which people are trying to discover for all the nerve blocks. And for sciatic nerve, it is well defined already. So if you take the upper limb blocks, the prevertebral fascia, which forms the paraneural sheath, so you can identify that and you can put the subparaneural injection, we can be safe. Now, of course, documentation, which is very important for a safe practice, medical legally safe. The rest of the things I think we do, then the few things that we might skip, like success of the block to mention, complete, partial, whether it is failed, or whether we have given any block supplementation. And this one, ultrasound pre and post injection image capture and storage. Maybe in the future we can do that. And always not to forget do a focused neurological examination prior to the block. Now, coming to vascular injury, this is a very good article saying about the risks, whether the particular block is an intermediate risk or high risk or low risk for the bleeding complications, which is defined by them by the occurrence of vascular puncture, then active bleeding and hematoma formation. This to both peripheral nerve block and interfacial plane blocks. Now, if you see in the upper limb, so all the interscalene to infraclavicular region, it is intermediate risk. Axillary, surprisingly, is low risk, even though there are a lot of vessels around the nerves, because you can easily compress the axillary region, so that maybe perhaps it is a low risk. Then, of course, lumbar plexus definitely in the lower limb is very high risk, and femoral nerve is intermediate risk. And the low risks are infrainguinal facial iliac block and your lateral femoral cutaneous nerve block and the ankle block. The rest are all intermediate risk. Now, coming to interfacial plane block, I think the quadratus lumborum block and paravertebral block, they have categorized data as high risk. The rest is all intermediate risk. Now, how to prevent or how to be safe from the vascular injury? Always pre-block scan that you do, or a scout scan that you always do, just to know the blood vessels, because the blood vessels resembles the plexus. And so use of color Doppler, then always visualization of the needle tip at all times. Now, you should know all the blood vessels in the vicinity and also the anatomical variations that is present, that might be present with some patients. Now, knowing the blood vessels in the vicinity is important, because if you take interscalene brachial plexus block, then you have transverse cervical artery, which comes anterior to the scalene muscles. Then you have in the supraclavicular region, where the dorsal scapular artery is right inside the plexus. So you have to know all those things. Then the suprascapular artery, which is in the vicinity. Then the cephalic vein and the thoracoacromial artery, which comes in the costoclavicular block. So you should know the named vessels and the anatomical variations, the other unnamed vessels as well, so that you are safe. So for that, you do a good pre-block scan, scout scan, and have a color Doppler help with it. Now, coming to compartment syndrome. Now, definitely the incidence of compartment syndrome is there, definitely 3.1 per 1 lakh, with the predominance in younger males with a large muscle mass stemming from a high energy activity and accident. So when this is there, then compartment syndrome is impending. Now, what are the common injuries? Tibial shaft fracture. So when we give block for tibial shaft fracture, soft tissue injury, or a forearm shaft fracture, we need to be careful whether to give or not to give. You will have to be weigh the risks, have a word with the surgeon, and whether there is a data or protocol, whether you can give it or not. I will come to it. Now, in pediatric population, older male trauma patients, firearm injury, then lower limb fractures, or increased risk of compartment syndrome. So what is the controversy? Regional anesthesia in acute compartment syndrome, whether to give or not to give? Yes, we have our Association of Anesthesia of Great Britain and Ireland saying that there is no contraindication for the usage of regional anesthesia in compartment syndrome. Having said that, so how to give a block? So I think the ESRA and the ASRA Joint Committee statement has given 6 best practice rules in pediatric patients, where you can give a single shot injection of a peripheral nerve or a neuraxial block that you can give. So in a compartment syndrome, you can go for a single shot block with a lower concentration, be it a neuraxial block or it is a peripheral nerve block. Now, if you want to do a continuous peripheral nerve block, the concentration of the local anesthesia obviously should go down, and then the rate. Now, with adjuvants, you have to be very careful, because it is going to prolong the intensity of the block. Then, as I said, you restrict the volume and the concentration. Now, with compartment syndrome, after giving the block, you should follow up it regularly. You should have a rounds of your own. Then if it is suspected, then compartment pressure that has to be performed along with the block. Then we have few societies saying that Great Britain and Ireland, that the dense block of longer duration is because of that should be avoided. A single shot or a continuous nerve block of lower concentration of local anesthesia without adjuvants is effective. Like you can give a block in a patient who is going to develop a compartment syndrome. And it is the same with the Academy of Orthopedic Surgeons. But the other societies have no consensus statements with regard to compartment syndrome. Now, this is from Hadzik himself. Actually, by giving a block, we are doing good for the patients, because it can help in the diagnosis of acute compartment syndrome when the block's effect goes and the patient is having a breakthrough pain. So that can help in the early diagnosis of acute compartment syndrome. Now, coming to postdural puncture headache, there are many societies which has formed. People from across the world recently published an article, which is the recent consensus in 2023. And this is infographic that they have released also. So what are the recommendations to be safe from PDPH? One is the routine use of non-cutting spinal needles for LP, which is recommended. Or if you are using a cutting needle, then you use a narrow gauge. Now you manage the PDPH with multimodal analgesia like acetaminophen and NSAIDs, which should be offered to them unless it is contraindicated. Then, if the patient, in particularly pregnant patient in the postpartum period, patient is having focal neurological deficit, visual changes and alteration in consciousness and seizures, in addition to the clinical features of PDPH, then you should consider neuroimaging to evaluate alternate diagnosis like Press syndrome. So when PDPH is refractory to conservative therapy and impairs activities of daily living, then you consider an epidural blood patch to treat the headache and the neurological sequelae. Now, when the site of the dural puncture is known, then where do you perform the epidural blood patch? Then usually, ideally, at or a one space below the level of the dural puncture. Obviously, you will have to maintain a strict aseptic precaution for collection of injection of autologous blood. Then informed consent for the potential for repeat dural puncture when you're going to give an epidural patch, backache while you're injecting the blood, then the neurological complications associated with it. So minimize the complications. Blood should be injected very slowly and incrementally. If significant headache or a headache is there because of the pressure paresthesia, then you stop the giving the blood and you wait. Now, before discharge, information regarding PDPS sequelae should be conveyed to all the patients with arrangements of appropriate follow-up and contact information with the anesthesia provider and the healthcare providers. Then follow-up with patients who experience PDPS should be continued until the headache resolves. Urgent monitoring and referral to the appropriate specialist, which is very important if there are other neurological deficit in addition to the headache. Now, coming to Phrenic nerve palsy, this is a very good review article by Vincent Chan and Jin Chin about the Phrenic nerve palsy. So how to have a safe practice in Phrenic nerve palsy. So the routine volume that you use for an interscalene block for a shoulder surgery to target C5, C6 is going to produce almost more than 90 to 99% of your Phrenic nerve palsy. So how will you modify to have a safe practice? One is low volume and concentration, and the site where you inject the local anesthesia and the technique that you use, and help of we have focus now, so you can assess the diaphragm as well, and then have an objective way of having Phrenic nerve palsy in addition to the signs and symptoms. Now, the other thing is you can do a Phrenic nerve sparing blocks by giving a suprascapular and axillary block or a superior trunk block with supraclavicular block, which is called the scud block. And the injection method, they have said that rather than a bolus injection via a syringe, the injury or the palsy that is caused is more than the local anesthesia that is deposited to the C5, C6 via a catheter. So through the catheter, when we give, the injury is less or the palsy is less. So now, how to support it? Like they have discussed, like when they have given 10 ml of local anesthesia, now the incidence of Phrenic nerve palsy came down to 60%, and when they went down to 5 ml, then it came to 27 to 45%. And coming to the concentration, from 0.2 to 0.1 ropivacaine, so the incidence from 71 to 42% is the Phrenic nerve palsy. But when you reduce the volume of the local anesthesia to prevent the Phrenic nerve palsy, they have said that there is no decrease, or there is no decreased efficacy of the block, where the duration of the block is good, the efficacy of the block was good. But when you reduce the dose to the half of the local anesthesia, then the duration of analgesia was less. So see, the expense of duration of anesthesia or analgesia, so we are going down on the concentration of the local anesthesia. Now coming to catheter or the continuous infusion, now the infusion rates of 4 to 6 ml per hour produce the Phrenic nerve palsy over 24 hours, regardless of the concentration. And this is a study by Renes et al., where there is no evidence of Phrenic nerve palsy 2 hours after the small bolus injection of 0.75 ropivacaine, the C7 route. But all the patients developed either partial or complete phrenic nerve palsy after 24-hour infusion of 0.2% ropivacaine at 6 ml per hour. Now, so how safe we are when you are giving interscalene block, of course. So you'll have to give an infusion rate of 2 ml per hour. And what is this wash off or reversal? There is an article by a person where they have used 0.9% saline to wash off the local anesthesia injection. Because by virtue of giving saline, it dilutes the local anesthesia concentration around the plexus. So this is one technique that, but there are more studies to come, should come to prove this. And so with respect to safe techniques, they've described a periplexus technique where you go 4 millimeter away from the brachial plexus sheath or outside the brachial plexus, which is called which is an extra facial injection actually. So outside the brachial plexus sheath and in between the perimysium. So you deposit the drug there. And there is another way to reduce the phrenic nerve palsy incidence is by giving an intravascular injection below the C6 level, where you can deposit the drug around C7, and the analgesic efficacy and the duration of local anesthesia action was the same with respect to your intravascular injection below C6 and the injection around C5 and C6. Now this is the focus where you see for your diaphragm excursion and diaphragm thickness. So you can have the help of your ultrasound to assess your phrenic nerve palsy as well. Next is the pneumothorax. Now this is an article where they have given infraclavicular and supraclavicular brachial plexus block, and they've studied between 2005 and 2013. And still with ultrasound guidance, even though with ultrasound guidance, this pneumothorax incidence has come down, still they had a 0.06%, which is only just 4 patients, but still it is there. Now, why in spite of USG, the patients develop pneumothorax, or we are producing a complication of pneumothorax? The reason is thin patients, there is an elevated pleural dome. That is the reason where in which in thin patients, when we give ultrasound guided block, can produce a pneumothorax. And if you consider obese and muscular patient, there is poor resolution and the nerve plexus are at a depth. So you don't know, if you are not seeing the needle tip appropriately, then you overshoot, then you go into the, you are going to injure the pleura. And the limitations of USG by itself can cause a poor image or faulty image setting, or the pitfalls of USG still that we are having can still cause pneumothorax when we give the block. And the difference between a resident giving a block and an experienced giving the block, then that is one of the reason patients still can have pneumothorax. So you can use the buffers, which is the first rib when you give a supraclavicular brachial plexus block, and you can take the help of the buffer serratus anterior. You can see between the cords and the pleura and the lung, you have serratus anterior as the buffer. So every time you see the needle tip, so that, and you should have the serratus anterior as the buffer. If you go little medially on the infraclavicular region, the serratus anterior will not be there. If you come little laterally, then the serratus anterior will appear. Then you take the help of serratus anterior when you are giving the costoclavicular block or a paracoracoid infraclavicular block. And if you have the probe little cranially, then the subclavian artery will be lying directly on the pleura. Now, if you tilt the probe towards the clavicle, when you see inside, distally inside the clavicle, then the subclavian artery comes over the first rib, so that you have this buffer to prevent pneumothorax. Now, coming to awake and asleep, whether to give the block when the patient is awake, or is it safe to give the block in G or in deep sedation? So what are the safety considerations? So in an adult patient, if you consider, then all the nerve blocks are recommended to be given when the patient is awake, definitely the intra-central neuraxial blockade and the interscalene block definitely 100% should be avoided in patients who are under general anesthesia or in deep sedation. Definitely that has to be awake. The other blocks you can give when the patient is uncooperative or something, or when the patient is not able to maintain their posture, like say in Parkinson's disease or something. So you have to avoid inadvertent nerve injury and vascular injury. So you can give a deep sedation and general anesthesia and give a block. And in pediatrics, of course, you will have to sedate the patient or give GA, then you give the nerve block because of the non-cooperation that you expect. And the safety standards, after you follow the safety standards for pediatric nerve blocks are acceptable also, still the serious complication can occur that has to be borne in mind. So it is better, according to ASRA guidelines, to give the block whenever possible in an awake state. Thank you. I would like to thank my own mentor and my inspiration, Dr. Harshal Wag, because I take this platform to thank him. I have never thanked him. Of course, personally, I've thanked him, but he needs that recognition. Of course, he doesn't need the recognition; he's reached that level. But I want to personally thank, because I never got the opportunity to thank him. So I thank Dr. Harshal Wag, my mentor himself, Dr. Murli Tondepave, who had little bit guided me on this topic, and all my mentors of regional anesthesia. Thank you, and thank you very much. If there are any questions, we can take over to Dr. Harshal.
Yes, thank you very much, Senthil. Quite nicely covered. We have got a few questions which have come on the chat box. We'll start from the first one. From what I can see is, I think probably Milind, or I think both of you can get. For the patient who has had stent after surgery, can we do rotem and decide on the epidural removal? That's quite a good thought, actually. Any thoughts on those ones? So someone who's had a stent after the surgery, can we do a rotem and decide on the epidural removal?
The patient who's had stent recently would be receiving some anticoagulants, and we usually would require at least 5 half-life of the anticoagulants to have elapsed and the drug to have been stopped before we consider an epidural removal. I think that's what even Harshal sir did for his complicated case that he's mentioned. He stopped the clopidogrel, I think, 5 days before, but you continued ticagrelor.
So the problem, I think, with the person who's already had some anticoagulants with the epidural in situ, the problem becomes is the cardiologist usually will not stop any anticoagulants if it is specifically for stents that have been put immediate post-op. So that's the dilemma that we had as well, because this, he was on full anticoagulation with clopidogrel and ticagrelor. Now, we were at a point where the cardiologist did not want to stop the ticagrelor, but we had to remove the epidural at some point. I mean, so I think the multidisciplinary decision was that we had to take the risk of a sort of risk benefit, where we had to stop the clopidogrel. We waited for 5 days for the clopidogrel effect to go, but unfortunately we couldn't stop the ticagrelor also. We had to just take that risk and do it. But we didn't want two anticoagulants on board, which would have doubled the risk. So that was the rationale of doing that, though there is no right or wrong, and there are no sort of guidelines of removal of epidural catheters on this. But yes, I see the point of that rotem is, I mean, you can do it as an additional medical legal aspect that you did check the rotem and remove it. But the counter side is, supposing you have a rotem which is abnormal, and the patient needs to be on anticoagulants because the stent has been put just immediately. Well, what do? You're stuck anyway. So you neither can you stop the this thing, and neither can you remove the epidural at that point of time. But the point can be done as you can do the rotem to sort of document it. But even if the rotem is abnormal, I don't know whether you can wait till the rotem becomes normal. That can be anybody's guess. So I think it's two sides of a coin, really. I think Amla madam has a question where if the wrong drug has been administered in a subarachnoid block, for example, tranexamic acid instead of bupivacaine, what would be the course of action? I think both of you can take that, because
So first of all, for us to recognize that a wrong drug has been administered in a subarachnoid block would take some time, because that's not a normal course of procedure that we follow. So that is only when the patient starts showing some symptoms that is not regular of a spinal anesthesia or a subarachnoid block with bupivacaine that we give. if we start noticing symptoms like severe back pain, pain in the gluteal region with burning sensations, and there are many reports in which tranexamic acid, which is a commonly given wrong drug in subarachnoid block, been reported. The patients, after complaining of pain and burning sensation, they've started throwing up seizures. And that is when we come to know that something wrong has happened. So, first of all, it's important to recognize. Second is to treat and resuscitate the patient immediately. When you see the patient is having seizures and all, his oxygenation is not been maintained, immediately sedate, paralyze the patient, intubate the patient, give him anti-epileptics, involve a neurologist who can guide on the anti-epileptics to be used precisely. And I think there is no antidote or reversal as such, but just to wait, continue with sedation, paralysis, and anti-epileptics. And there are reports in which the patients have recovered, and we've been able to wean them off the ventilator in a course of 3-4 days, and they've shown full recovery from their neurologic uh, deficits or problems.
I'd
And
just like to add one more point. There is yeah, sorry, Emil, carry on. You were saying
no,
something.
sir. Yeah. Retrospectively, we must just identify what was that wrong drug which was given, and it should be reported at least, which doesn't happen usually because of some fear of getting a negative publicity. Yes,
Just
sir.
pertaining only to tranexamic acid, I think there are surprisingly so many case reports of tranexamic acid being given intrathecally. I think if you see the case reports of the earlier years, I think the mortality was quite high. If you see the recent ones, there's I think one of 2023 as well, where the patient has not died, but obviously has had some. So they have I think one or two case reports of trying to put a lavage into the subarachnoid space by using a normal saline. So I was just reading about it where they realized that the patient has been had tranexamic acid, and obviously doing all the the intubation, and because they go into severe spasticity, so you need some sort of muscle relaxant, so you intubate and all these things, and anticonvulsants. But this couple of case reports also did lavage. So basically they put two spinal needles and different levels, put saline to reduce the concentration of the tranexamic acid, as well as drained with one needle up and one needle down, and put some saline and drained it. That apparently helped in their case report. At least it's not something that is recommended in terms of by bodies, but these few or couple of case reports too. I think Dr. Yogit also has this. Any precautions when regional anesthesia is planned in septic patients? Any thoughts on those? Whether we can give, if there's already an infection there, would you give any blocks? And
Yeah, so there are reports and recommendations wherein if we have a diagnosed and a known case of bacteremia or septicemia, and if it is not central neuraxial infection involving the meninges or something, then we can definitely go ahead with a regional anesthesia provided the risk benefit is evaluated, and definitely under cover of high antibiotics.
And there are two questions which are pretty similar: is legal consequences if nerve blocks are given in a peripheral neuropathy, and whether if already a neuropathy, already nerve injury, can we do an upper limb blocks? I think we can probably combine the answer both of them.
So a nerve block in a peripheral neuropathy is a double-edged sword. There are peripheral neuropathy is a broad term wherein it involves dysfunction, sensory motor, abnormalities of the nerve. But again, it is to have the risk-benefit ratio to evaluate the patient. If the patient really needs the surgery to be done under regional anesthesia, wherein the risk of general anesthesia is too much for his life. And also there are reports in which there is something called as double crash phenomenon, in which injury with a nerve block would amplify his already existing neuropathy. So that is something which we need to be aware about, and definitely about documentation. If you are performing a regional anesthesia in a neuropathic patient, then have a detailed documentation of what sensory motor neurodeficits that the patient has, so that in the post-operative period, and at least know if there's some new neuropathy which has been developed.
I would
I
like
think
to
it is.
add on that question.
Yes.
Like in case of peripheral neuropathy, you have to know what are the deficits with peripheral neuropathy. So you need an informed consent about the regional block that you are giving and the risk and the benefit ratio that you are going to do. Because without a peripheral nerve block or an interfacial plane block, which is considered as a preemptive analgesia, and the blocks, we have studies where say the blocks prevent chronic pain in the patients. So even if the patient is having peripheral neuropathy, whether it is just only the sensory deficit or the motor deficit, and any hereditary disorder, even though the double crush phenomenon is there, where the along the neuro axis, the neural axis, the neural injury can happen at a place distinct from the primary lesion. You can have an informed consent and you can do the procedure. So as such, we don't have any experience of a peripheral neuropathy or consequences of legal thing. I don't have any examples to tell. And in case of this radial nerve injury preoperatively, where the humerus shaft injury, radial groove injury, where the patient is having radial nerve preoperatively, then you can still give a nerve block to cover the myotome, dermatome, and osteotomes of the other than the things covered by the radial nerve, like median nerve and musculocutaneous nerve and your you can choose an axillary brachial plexus where you can individually target the individual nerves other than the radial nerve also. So if I have to give a upper limb block in case of radial nerve injury, I still can go with the block based upon what is the surgery to cover the other osteotomes, dermatomes, and myotomes.
So documentation and informing patient, and then making sure that you're not doing something that is out of the ordinary is something that you should always, and within the guidelines is something that it should always be. Now, I think a couple of questions regarding intralipid is whether you can give parenteral lipid infusions or these ones, that is the total parenteral infusions instead of intralipid if intralipid is not available, and can intralipid be used to reverse phrenic nerve palsy?
I think the parenteral lipid infusion emulsion and the intralipid is same, but
no, they're
that's
not the
what
same. I think TPN is
I-
different and the intralipid is different, but I don't know whether there are any case reports whether you can use a TPN for Yogita. Do you have any information on that? I have no idea whether TPN can be used for intralipid, because that's something that is not recommended by any bodies as such, whether you can use TPN for local anesthetic toxicity.
I don't think the formulations are completely different.
Different, yeah.
So I guess for safety issue, intralipid is only the preferred solution, and that's why probably no recommendations for
Yeah, no
it.
recommendation. I don't think you can use intralipid even to reverse a phrenic nerve palsy. I don't think there is any evidence for
There
that.
are no evidence as such. I just want to add, sir.
Yeah, there's
There are no
evidence.
evidence whether they have used intralipid to reverse phrenic nerve palsy, because I think intralipid, the mechanism has said it is lipid sink, where it causes a concentration gradient between the myocardium and the intralipid as
it
such.
is basically used when there is a cardiac event or a cardiac instability.
So logically, around the nerves and the intralipid, whether it will cause concentration gradient and will reverse, we don't have any studies as such. But there is one study where you can wash out with saline and decrease the concentration of your local anesthesia around the nerves.
I think Sami Deshpande is asking whether we can get a injection pressure monitor. I think Payunk is manufacturing the pressure limiter, which is a green one. The pressure injection monitor, I think B Brown has it. I think who has
Yeah,
it?
B Brown.
Yeah.
Oh, injection guard is by, I think,
Payunk.
Yeah.
Injection guard is by Payunk.
when the pressure automatically increases, the pressure guard will cut off the local anesthesia injection.
Dr.
There is
Srinath
an
is asking
inline
if
pressure
anybody's,
manometer also.
yeah. Dr. Srinath is asking if anybody has seen a cardiac arrest following an intrathecal tranexamic acid. Fortunately, I haven't. I don't want to also. I think a little difference in terms of the tranexamic acid ampules that we get are different in India as compared to what we used to see in the UK. The UK ones are pretty much similar to the bupivacaine. Our bupivacaine ampoules are also different, at least the ones I've seen so far. Whereas in UK, if I remember, the tranexamic acid and the bupivacaine are clear ampoules and they're pretty much similar looking. I've not seen similar looking ones so much here, but I might be wrong. Every company is different. What else is there? Will the patient feel pain under block when nerve repair is done or when the nerve is trimmed? Interesting.
Sir, I didn't
Will the
understand.
patient feel pain under the block when nerve repair is done or when nerve is trimmed?
Yes, I have an incidence where I had given a block for the, I think, AV fistula in the radial region by our vascular surgeon. I think when he had touched the nerve, patient under the block, the patient had pain and he just lifted his he shouted, like he winced with pain. So I think you can feel the pain under the block when directly the nerve is touched or manipulated. I
I
just have
guess
one incident.
I guess in plastic surgery in KM, we often do nerve repair under block. So if that block is acted well before the starting the surgery and the duration of anesthesia is, complete, probably they don't feel pain. But if there is a sparing of
Yeah,
nerves,
correct.
they might perceive the pain. And as the local anesthetic action wear off, that time they may perceive pain. So we often do immediate nerve repairs under regional anesthesia in KM because plastic we do get very often crush injuries. So even now tendon repairs we do it. But tendon repairs for motor functionality we avoid blocks. But for nerve repair we can do it provided documentation and the medical legally documentation of nerve injury is done properly. So medical legal issues are also avoided then.
Yeah, the next one is how do you measure the pressure while injecting local anesthetic in peripheral nerve blocks during PNS? The nerve guard comes in front of the needle, so you can use it while using a PNS as well. It's nothing to do with only ultrasound. It's just injection pressure which you can use for any needle. It sits on top, it sits in front of the needle. So even if you use any needle, you can it connects between the needle and
And the
the
syringe.
syringe. So you can use it on any syringe if that answers the question. Dr. Samir is further asking is nerve injury has happened, how to inform and counsel relatives? I think Milind, you can take that. I think you spoke to in your talk as well, but you can probably do that again.
You have to anyways inform, but you to find the reason of nerve injury would be difficult because if documentation is there when you know that you were on or are an inadvertent nerve injury, then you have the pictures of ultrasound or whatever it is. So you will have to rule out first the other causes of nerve injury other than the regional nerve block that they have given. Suppose if the surgeon had sent the patient to us, anyways, we will have to inform and counsel the patient for the follow-up, for the further management with electroconduction studies and electromyography. So the further investigations, then you can counsel the patient that the nerve injury is only reversible most of the times, which is conduction block, neuropraxia, which is usually reversible, and permanent nerve injury is very, very rare. And so usually we follow up it to 1 year. So we will have to explain in all these aspects, like you will require a follow-up, you will require multiple investigations, multiple people will be involved. Then we will be giving you the symptomatic management and all those things. So uh, this is what I think we can do.
I think
Just to
documentation goes a long way in. Yeah, I know there is one aspect where you're definitely sure that you have caused a nerve block, but when you've done a block extremely well, and in spite of that you get the reason why I'm talking about this, I'll tell you an example which we got patients with a son who was working in the US, so very well read, and our block was for the shoulder, very straightforward block. We used the ultrasound, we used the injection pressure monitor, and for that patient I didn't use the PNS, yeah, because nowadays PNS, we're not using it well, but because we use the injection pressure monitor, he had read about it in somewhere, and he said, did you use all modalities to prevent nerve damage? I said, yes. I said, we didn't use the nerve stimulator as well because nowadays we are giving it, we don't use it as such and we are doing it at ultrasound guided. But he had specific questions. Did you use a pressure monitor? I said, yes. And have you documented? I said, yes. So that saved us from the medical legal. Otherwise, he was almost ready to sue us, though the block was straightforward. So something that if you have the modality, use it and document it. That is the take-home point in terms of these nerve repairs.
I think I had one slide now, sir. Like safe, safer, and safest,
Yeah.
like in the degrees of superlatives and all those. So safer is even dual modality is safer even if we have not used an injection pressure monitor. I think it should be still safer. Like safe anesthesia practice, as a safe regional anesthesia block we had given. And as of today, I think the peripheral nerve stimulator is just for the nerve needle relationship when we use it with ultrasound as well. So as such, we just have moved from the nerve stimulator to the ultrasound as. So if we have to use it as a dual modality for safe practice, if you understand, then it is only for needle nerve relationship as such, not providing the block and anesthesia and analgesia by itself. That is one thing. And definitely, if if we have evolved or if we have done multiple blocks and we are good at ultrasound guided blocks without using any peripheral nerve stimulator or any injection pressure guard or whatever it is, deep blocks like lumbar plexus block, definitely it is recommended that you use dual modality, both peripheral nerve stimulator and the ultrasound. Deep blocks, definitely, like lumbar plexus and sacral plexus.
I
To add
think
one
Dr.
point to it.
Sona. Yeah, sorry. Yeah, carry on.
Yeah. So in this nerve injury, it is always a good practice to scan the area of interest before giving the local anesthetic and after giving the local anesthetic. Because if you see a nerve swelling after giving the local anesthetic, that means the nerve damage has already been happened. And but if you are well sure that after giving the local anesthetic, your area of nerve is still intact and there is no breaching of any neural tissue, then you can maybe probably think of it from a surgical point of view, that has that nerve injury been occurred because of the surgery.
Yogita, I think there's a question for you by Dr. Sona. Why not?
Yeah, actually, Shweta ma'am is also there. She can add further, but I'm sure when we want to test a functionality, a block is given, so muscle cannot move along with nerve, even the muscle is affected. So, like, especially finger, that small tendons, they are repairing. They don't want any block to be given in such patients. And even sometime, even functionality by muscle, like muscle testing is done. That time, even muscle relaxants are supposed to be avoided. So that's the sole reason. But when they don't want to test any functionality of muscle, we can go ahead with regional blocks.
Yeah, because for nerve, hello, can I speak?
Yeah,
Yeah,
madam.
you can, ma'am.
Yeah, because for nerve repairs, I'm not giving and this thing, but for tendon repairs, we are giving, and the surgeons don't mind it.
Shweta ma'am,
Yeah,
want to add something? Yeah,
yeah.
sure.
So a few of our plastic surgeons, they want to identify the tendon fibers, and some of the tendon fibers, they want to transfer it to peculiar areas where they need the finer functions in the distal interpharyngeal phalangeal joints or in proximal. So that's why they want to be sure that the patient has regained the function that for which they are doing
No,
the
but
surgery.
under anesthesia, how will they this
That's
thing?
what my question. So you're giving GA without
Yeah.
muscle relaxant. Is that what you're saying, madam?
Even if
So
you're
we
giving
are
without
not,
muscle relaxant, how are you going to tell the patient to move?
yeah, so we give 0.25 ka block. Okay, that is the block in the sense is the surface anesthesia that we give. Surgeons will give, they will infiltrate as they go, and it's a 0.25 or lesser than that. And we give tourniquet block because these things are done under tourniquet. So they need the clear field. So we give tourniquet block and they infiltrate as they go. And that's where they do the, we give our sedation, but patient is arousable. We can communicate with the patient and patient is comfortable at the same time. So they, generally it is the palmaris longus tendon, few fibers, they would want to transfer it to some of the deficit areas. So that is what primary nail filtration, it's more like a tumescent which they do it, and they use a sensory concentration basically. You can play with the concentration of sensor cane or ropivacaine as you want it. And that's
But
where they have
but
the motor function.
such deep surgeries, do you mean they do under local?
It's not deep surgery, na? It's fingers you are talking of, and the wrist and the finger.
No, but
So that is, the tendons are quite superficial there. So sometimes what they have to do is that tunneling where they've infiltrated the 0.25 bupivacaine or ropivacaine.
But
Half
how do they check it then?
concentration.
How do you check then? They stimulate it and see.
No. They tell patient to move the
Acha,
finger.
okay.
The joints are then moved. They will say that flex this joint, and they will see whether this is the right attachment or not.
Okay.
Because they are very fine functions to look at. That's
Okay.
what they are operating for. If they don't achieve at the end of it, then like it's all a big waste. So that's
Right.
what they do it, but it is very peculiar to surgeons, peculiar surgeons. Not all might do the same. But this is what we have found the best way, because they want to do like an awake thing, and this is the only way that we can provide, because at the same time they want the tunique also, and they want the patient totally pain free. So this is the best that we practice.
Right.
Okay.
That makes patient comfortable, patient is arousable, and at the same time cooperative but pain free.
Okay, because directly when they're stimulating and all, we do it under TIVA. That is a different thing. But this,
That is no. That's for
yes,
nerve. This is
yeah,
primarily for tendon that they see it.
okay.
Yeah.
Thanks, Yogita, Shweta, Harshal. Ha.
Thank you.
Yeah. Thank you.
I think one more question is how to differentiate postoperative inflammatory neuropathy and neuropraxia.
As I said, postoperative inflammatory neuropathy is by the microvasculitis, which causes axonal damage. And neuropraxia is myelin damage mostly, where in neuropraxia there is conduction velocity which is delayed, and in postoperative inflammatory neuropathy, by virtue of axonal loss, the amplitude of the nerve conduction study will reduce. So that is how you can. So basically, it is postoperative inflammatory neuropathy is axonal loss, and neuropraxia is just the conduction block by where there is no myelin in it.
So maybe here in neuropraxia is primarily sensory, and neuropathy may have a motor weakness component.
Yes, both.
Yeah.
Good point, man. Yes, that's true.
Hello,
Yes, sir.
may I speak?
Yes, sir. Please go
Yes,
ahead.
sir.
There are incidences in past accidental injection of tranexamic acid, which you were also discussing in this discussion. So why not we say the companies to change the color of the bupivacaine?
So you're
we do
saying that we
have
should
change
recommend to
in
the company
color
to
now.
change? Yeah. I think that has been done many times
Yeah.
before, I think. So
The ampule size is same, and sometimes in hurry, assistant or even junior doctor may give it
yes.
sister. We should say they should be packed in some different matter, different kind.
I think there is a separate thing for this look alike and sound alike. I think that discussion always happens is where the ampules look alike, and when they say also when you're passing on orders when they sound alike. I think that discussion always happens, and the safety forum is always wanting to keep these things in mind where they want to make sure that the ampules are different. But nowadays there's so many companies, though I think they're getting
No,
the
if we say the directive of companies, they convey the things to the higher authorities of the company. When previously, when there were lack of needle, needles, instruments, etc. You can say in government hospital, peripheral hospital, small hospital. even LP needle were not available, we used to do LP by stilate of the spinal ventriculum. Then companies started giving cotton filter so that the blood will not come when it is in the vein. We asked them to stop this and continue the old model because we are using it as uh, a spinal needle. Though nowadays, I think this was foolishness, and I use 27 gauge needle, and even 23 gauge needle sometimes causes the postdural puncture headache. And at that time, we were using stilate, which causes a hole in the dura. And because in government hospital, fluid was given 2 3 days, patient was taking rest for a long time, and even in private also. So that leak was masked under this. But nowadays, in my setup also, operation is done, cesarean operation is done, and after 12 hours, fluid is allowed, patient is allowed to walk. So in this condition, we can't think giving a spinal uh, of that kind. So I mean to say कि we said the company to change your needle and give plain needle. Similarly, we can say कि kindly change your packing
Ampule, looking ampule to look
ampule.
differently.
Ampule can be made broader and shorter. Some injections, some ampules are and in height shorter. Here, bupivacaine and tranexamic acid ampoules are of same size, same look.
Okay, sir. We'll pass on the message to.
So, so as per NABS, we are
If
supposed
all,
to
if
train our staff nurses for sound-alike and look-alike
Yes,
drugs.
yes.
It is mandatory as per
if
the
if all
NABS.
the doctors say the company जो the main company is Neon है, Trico एक आया है, and whatever other main companies Neon हो गया आपका ये एस्ट्राजेन का तो
Yes, sir. I got the
they
point. We'll pass on the message to the companies to make sure that the ampules are looking
जी जी
differently, so the amount of
कलर
look-alike,
कलर
sound-alike is different.
So
change the
one more
color
thing
some
is,
bright.
sir, before injecting anything, the way Dr. Senthil told, stop before injection, read loading, two people read
Yes,
the
two people.
ampule
Yeah,
shown. So these are
Yes,
the
yes.
small precautions we can take. Whoever is giving the injection should read, one more person should read the label and then inject. Again, before injection, reconfirm what you're injecting. This is a small thing. For
correct,
look-alike, it can help.
correct.
You are right, but um, initially in beginning, everybody thinks that
Now the
this
brands are very different. The labels are very different, sir.
this
Nowadays, they are
major
really not very look-alike. The color
this
of the
major
sensorkin
error cannot
ampules and
occur.
vials are different.
अंदाज से दे देते हैं ना, मेफेंटीन की जगह इस सक्सिनिल कोलिन के इंजेक्शन दे देते हैं इंट्रामस्कुलर. At the end of the operation, when BP is low, I also used to give termine that will keep blood pressure maintained for some time till the effect of the spinal will be enough. Once a doctor given succinylcholine, but because it was intravascular, by the time the effect came fully, it started going bleeding also, and patient was saved. I always ask my OT workers to keep all the dangerous things separate in the box.
Right.
Yes, sir. Points well taken.
Yes, sir.
And people are taking precautions nowadays. So we can
जी जी
go
जी
ahead with next session, question, Harshal, if at all
Yeah, the
any.
next is it medico-legally a compulsion to accompany a PNS guided block with USG, where we have clear guidelines in PNS also where less than 0.2 milliamperes avoided for intraneural injections.
There are two things to it, like few things to it. One, as of now, PNS is for only nerve-needle relationship along with USG because we are giving USG guided blocks everywhere. That is one thing. Second thing is always for safe practice, yes, of course, dual mode you use or the triple modality that you use. So most of the times there are studies which say that even if your current is less, if your current less than 0.2 is stimulating, having a motor response, but the patient, if you see the needle, you are not in the intraneural area, or it is the other way about. You are in the intraneural region, you still not having any stimulation with 0.2. And only with PNS less than 0.2, sometimes even with PNS and the needle is inside the nerve. Even ultrasound, when you're giving the block, the needle is inside the nerve or in the periplexus region, but the stimulation is not seen or there is no response less than 0.2.
So from medico-legal point of view, there is no compulsion to use the PNS along with USG as of now, because now the USG guided blocks are becoming fairly norm in terms of doing it, enough evidence case reports as well. But looking at it, now if you ask me personal opinion, I would probably use all three modalities just for the fact that if there is a nerve injury of that patient, the patient's relatives or somebody is bound to ask, did you use all modalities that are available in your hospital to make sure that the nerve injury does not happen? And that sort of gives me a saying that yes, I do have PNS, I've used it. I have ultrasound, I've used it. And yes, I do have injection pressure monitors, I've used it. So I have done my best according to my institutional practice, that I have used all available modalities to prevent and update the block awake. So I've used everything possible under my armamentarium to make sure that the nerve damage does not happen. But in spite of that, if it happens, then it is unfortunate, but at least I have done my bit in terms of doing my best to avoid it. So medico-legally, I think even that the same question is probably going to be asked by someone who is a non-medico. The question is going to be asked from the opposite side is the same thing. Did you use all modalities to prevent nerve damage? He said, yes, probably I did use that. So I think that probably gives you a, I don't know why my color has changed, but it probably gives you a best choice in terms of defending yourself. That's what I think. I don't know whether Yogita or anybody else has to add something. Or Amla madam or Shweta madam, if you have to add anything different. I would probably use all three if they are available.
It depends on the setup, the way you
Yeah,
told that
correct.
whatever best available, we should explain that whatever best is available, because we do have all three modalities available, but all places it may not be. That's why these safety things have come, that minimum standards has to be followed at least.
Correct.
So that, at all level, we are anesthetizing the patient in a safer environment.
Great. I think that's the end of the
If you
questions on the
have,
chat box at least.
Yeah, Shweta ma'am?
if we have all the three modalities available, we may use, but I'm sure all of us may not have all three,
Yeah,
and time also is a concern. So, because the PNS also, it might, everything takes time, consumables cost increases. So, at least ultrasound is the accepted standard of care. It's not, I don't think in medical legal thing that you will be questioned, why didn't you use? As long as you have used one modality which is kind of recommended. So, that's what we follow. Most of us follow the same. So, yeah.
thank you.
Okay. So I guess we can wind up the session now.
Yes, I think we have done. Thank you, Milind and Senthil. Thank you, Dr. Yogita.
I
Yes,
thank
bye.
Dr.
Thank you.
Amla
Thank you.
Kudalkar for this excellent topic. I thank Dr. Sona Dave, ma'am, for giving the inputs. I really thank Dr. Harshal for moderating the session excellently. And obviously, both the speakers have done a fantastic job. They have really started from basics to really advanced modalities. So really thankful to nice presentation. I thank all the SAM's office bearer for always supporting us in all the webinar tie-ups and giving the platform always. I thank Mr. Ganesh for all the technical help. I thank all the delegates for attending in large number and putting forward their questions, and we could solve their queries. I could see very, quite a few of senior members. I'm really felt privileged that they are attending the webinars, and even few sister branches, office bearers, and people are attending it. So I'm really thankful to all of you for making this webinar successful. So good night, all of you. Thank you so much.
Thank you.
Thank you.
देखिए आज ये अपना चेहरा नहीं दिखा सकते, आज हम भी अपना चेहरा नहीं दिखा सकते, ये कहीं इनकी जान खतरे में आज आपको विश्वास नहीं होगा कि 70 की शाही जामा मस्जिद से लेकर अजमेर शरीफ की दरगाह तक, दिल्ली की कुतुब मीनार तक, लाल किला, आगरा के ताजमहल और काशी की ज्ञानवापी मस्जिद का ये जो मामला है, ये पूरा की पूरा एक दूसरे से जुड़ा हुआ है। इन सब